Good morning and welcome to Davies Use Case webinar being presented by Miami Children's Hospital System, CAUTI infections. This is Davies award-winning use case for the value of health IT. My name is Arnold Simmons and I'm the manager of quality and patient safety, and it's my pleasure to moderate this presentation. Core HIMSS mission is promoting the use of health IT to improve the quality of healthcare delivery, promotes and advocates the integration of clinical decision support and practice guidance, adds clinical data to analyze progress, and he enabled patient safety tools for all healthcare organizations, clinicians, patients, and community members as vehicles for improving patient outcomes. HIMSS Nicholas E. Davies Award of Excellence is the pinnacle of HIMSS Value Recognition Program. The Davies Award recognizes the outstanding achievement of organizations from around the world who have used health information technology to improve patient outcomes and value. The Davies Award-winning use cases have been peer-reviewed to validate sustainable, improved patient and business outcomes resulting from health IT able delivery measure. Our speaker for today's webinar, Anna Colina, has with Miami's Children's Health System for 10 years, transitioned into a clinical systems analyst at the beginning of the year, where her role includes optimizing the electronic record clinical workflows, data extraction and analysis, amongst other responsibilities. Prior to transitioning into her current role, she worked in the pediatric intensive care unit for 5 years as a registered nurse. In 2012, she became one of the designated electronic medical record trainers for 5 years within the Learning and Development Service Department. Diana, thank you for joining us today, and I will turn the presentation over to you.
Thank you. Okay, so we'll be over the next few slides. We'll be going over catheter-associated urinary tract infections, also commonly known as CAUTIs. Okay, so background on CAUTIs. UTIs are among the most common type of healthcare-associated infection. UTIs acquired in the hospital setting, 75% are associated with a urinary catheter. 15 to 25% of hospitalized patients receive a urinary catheter during their hospital stay. The most important risk factor for developing a CAUTI is prolonged use of the urinary catheter. Their catheters should only be used for appropriate indications and should be removed as soon as possible. Associated with increased length of stay, increased health costs, morbidity and mortality, and preventable antibiotic use. When you compare the adult and pediatric population, a urinary catheter for a pediatric patient is a traumatic experience from insertion to removal. Young children don't understand why they have a catheter and a bag attached to their body, let alone not being able to move freely and play. Okay, so looking at our local problem, in 2015 we had an infection rate of 2.9 CAUTIs per 1,000 device days, a total of 7 CAUTIs for the year 2015. With our whole problem in mind, we set a goal to reduce CAUTIs by implementing the CAUTI bundle best practice guidelines using the electronic medical record system. Looking for local problems and focusing on enhancing the child's experience within the hospital setting, we researched on how to improve our CAUTI rate. In 2009, the CDC published updated guidelines for prevention of CAUTIs. These guidelines included recommendations for a CAUTI bundle. I think, what is a CAUTI bundle? A CAUTI has three components. The first is use of appropriate technique for catheter insertion, which includes hand hygiene, catheter only used when necessary, and maintaining sterility. The second component entails ensure appropriate management of indwelling catheter. Those include properly securing the catheter, assessment of urine, maintaining a closed sterile system, and unobstructed urine flow. Thus, two of the bundle we were already meeting. Implementation of special projects, special programs we were curious about. Special approaches included using electronic or other types of reminders of the presence of a catheter and required criteria for continued use. We got a team together and started our CAUTI workflow journey. So it entailed the following: a clinical systems analyst, other MIT, infection control nurse practitioner, a nursing director, an operations nursing manager. Majority of our implementations, we like to include a subject matter expert from every area where the implementation is taking place, and this project was no different. So we included also a medical surgical RN, an ICU nurse, a physician, and for training purposes, education. Looking at timeline and changes, the saying "a little goes a long way" was very applicable with this project. We were able to make small tweaks to the electronic medical record and workflow, which in turn made impactful difference. The project had a 1-month timeline, including weekly meetings with the team. It was completed in a non-productive production environment. The changes were small to the workflow. We provide informal training. In the next few slides, we will go to the urinary catheter workflow. The two changes done to the urinary catheter workflow was a change to the initial instant urinary catheter order, and the second was an additional task to the nurse. In this slide, you'll see what our urinary catheter insertion order looked like before changes. Okay, the provider would go in, type in urinary catheter insertion order, complete urinary catheter type, indwelling or straight, and move forward. The change was done, like you see in this slide. You'll see the provider goes in, puts in the order, urinary catheter insertion, completes the urinary catheter type, and we're using in this example indwelling, the third field called urinary catheter protocol. The catheter protocol section is what triggers the reminder, which we'll speak to in a few slides. Once the provider puts in the urinary catheter insertion order, the nurse then receives a task to insert the urinary catheter. He inserts the catheter, then comes in here, double clicks on that task that you see your urinary catheter insertion / discontinuation, documents the insertion. In the next slide, you'll see that as well. Slide writers or this section requires he or she to document the actions of the urinary catheter insertion. Okay. As per CM protocol, the nurse then documents, assesses and documents on an hourly basis. If you take notice, many of the documentation sections meet the CAUTI bundle components 1 and 2 as mentioned before. Those include perform cath care, daily chlorhexidine bath, cleaning the catheter, draining freely, so on and so forth, that meet the components 1 and 2. The urinary catheter workflow that we updated to improve our CAUTI infection rate include urinary catheter necessity review, included a reminder of the presence of the catheter. We did the urinary catheter necessity review with provider task as a reminder. This task triggers 48 hours after the catheter insertion order is placed. We have shown that after 40 hours with a urinary catheter, the patient is at high risk for developing a CAUTI. That's with the 40-hour time frame. Okay. All right. So it goes ahead. She received that urinary catheter for necessity review with the provider task, and here she does he reviews the necessity for the catheter with the provider, and one of two things happens. If they decide that the patient does not need the catheter anymore, you'll see here on the first page, on the top of the page, the nurse goes ahead, document order obtained to discontinue urinary catheter, and who she reviewed it with, removes the catheter, and moves on. Now, the patient meets indication for continuation of urinary catheter. You'll see on the second screenshot here they would document meets indication for continuation of urinary catheter, reviewed with, and why patient meets exclusion. So in this case, we selected critically ill requiring strict eyes and nose. Okay, if they go with the catheter, the system will trigger another task for review with the provider in 24 hours and will continue until the catheter is removed. Okay. Now, a summary, again, our baseline period of 2015, again, we had an infection rate of 2.9 CAUTIs per 1,000 device days, total 7 CAUTIs for that year. In 2016, after the implementation, we decreased to 1.28 CAUTIs per 1,000 device days, with a total of 3 CAUTIs for that year. The CDC set a goal to reduce baseline CAUTIs within 5 years by 25%. Not only did we meet the goal, we decreased CAUTIs by 57% in 1 year versus 5. Taking out a few graphs here, the first one tells you total CAUTIs. So you have the gray bars, which give you total device days by quarter in 2 years, and the green layer, the green graph gives you the total number of CAUTIs, again divided by quarter. Okay, you see the orange dotted line, there is a general trend downward as well. Okay. The next graph gives you number of CAUTIs per 1,000 device days, again divided by quarterly. So your green linear graph gives you the number of CAUTIs quarter, and you see the orange dotted line going general downward direction as well. Okay. The next graph is on CAUTI cost. You've got your orange bar graph. It gives you your cost per quarter. On average, a CAUTI cost about $758. In 2015, we spent $5,300 and change, and in 2016, we reduced the cost by approximately $3,000. Okay, so in the next graph, you'll be able to get a bigger picture. Again, we've got CAUTI cost. 2015, we spent $5,300 on CAUTIs. In 2016, we spent $2,274. We saved $3,032. One thing we monitor is our CAUTIs, and the information is not only available to clinical informatics team, it's available to end users. This clinical excellence index section is available on the organization's web portal, where every staff member can visit and see how we're doing. Okay, So looking at future states, because we're always looking to improve. A little overview here, we've got 2012 is when we implemented our EMR and we went live with standard urinary catheter documentation. In September of 2014, we updated and implemented the CAUTI bundle documentation changes. In 2017, we are actually looking to implement another bundle, which is called Houdini bundle. So Houdini stands for hematuria, obstruction, urologic surgery, decubitus, intake and output, neurogenic bladder dysfunction, and mobilization. So this bundle works is it's nurse-driven. So if the patient meets any of the criteria of Houdini, as I just mentioned, the cash stays in place. If the patient does not meet any of those criteria, the nurse can go ahead and freely move it without any provider order. Okay. Last but not least, you've got change management. So any that we do, it goes through a process, and are not just suggested by a clinical informatics or certain staff members. We get them from all end users. So if an end user is working at the bedside and they think of an idea of how it can optimize the workflow, they're go ahead and go through that process, but they do have to go through a change management process. So they start off with their idea, they come to certain councils, and it gets approved or denied, then they move forward until it comes to us in IT, and we go ahead and make that change. Okay. That'll be all for CAUTIs.
Oh, thank you, Ariana. Thank you for joining us for the Davies webinar today, presenting on CAUTI. Davies use case webinars and information on how to apply for the Davies Award can be found posted at the HIMSS Davies Award website at hims.org/Davies. And that will today.